My name is Conrado Coutinho from Brazil, and it's my pleasure to have the opportunity today to discuss with you a little bit more about point-of-care ultrasound for those pregnant women that come to the maternity suite with symptoms of threatened preterm labor. How should we manage these patients? So nowadays, we are using more and more point-of-care ultrasound on our daily practice. And here we have lots of examples of equipment that we can use using our portable phone or tablet devices. Some of these can be used for obstetric purposes with a sonographer or a medical provider. Others could be used by the proper patient, but with these images going directly for assessment of the supervising doctor. And nowadays, more importantly to this presentation, we have also the opportunity of having transvaginal probes that can be used with handheld devices or our usual portable devices. These are examples of the ones that we have in our maternity here in Ribeirão Preto, but more importantly, with transvaginal probes, as we are going to discuss in the next slides. So we are using more and more. We are stimulating in our service the training of our trainees for this point of care assessment. So every patient that is admitted in our hospital, we offer an ultrasound assessment for assessment of the presentation of the baby, if this patient is going to have an induction of labor, for instance. We assess the estimated fetal weight. Sometimes in the proper emergency room, we use the ultrasound for transvaginal assessment and assessment of the cervical length. This is what we are going to discuss in this presentation. And well, sometimes we use the point of care ultrasound for less common practices, such as checking a fractured contraceptive implant in one of our trainees, and this was removed and confirmed this fracture. And another use of the POCUS is to guide surgical procedures. And in this unusual case, we also had the opportunity to use ultrasound to guide the removal of a broken needle inside the cervix and the isthmus of the uterus of a non-pregnant patient with success, as you can see here. But let's talk about preterm birth prevention, the theme of this lecture. We have lots of opportunities to predict and to prevent preterm birth during every pregnant women consultation. Since the first consultations, we have the opportunity to identify risk factors, to control the diseases that these patients might have, to improve or to implement lifestyle modifications. These would be primary prevention measurements. Of course, we also should use secondary preventive measurements such as prediction of preterm birth by the use of ultrasound during pregnancy and management with some of these procedures here that can or cannot be used depending on the cervical length measurement. But irrespective of doing these primary and secondary preventive measurements, some of these patients are going to come to our maternity suites complaining of uterine contractions. And we have to do a proper diagnosis of the risk for delivery in the next days or not, to try to decide if these patients need hospital admission, tocolysis, or any other of these measurements here that you can see in the slide. So this is our clinical situation, and it's not uncommon. More than 15% of patients that come to the emergency maternity consultations, they have symptoms of uterine contractions. But are they really at risk of delivering in the next 7 days? Well, most times this situation is not going to happen. In 1/4 to half of cases, patients that arrive with complaints of uterine contractions, these contractions stop spontaneously. They're not going to delivery in the next days. In fact, less than 10% of these patients are going to deliver in the next 7 days. And from the total number of these patients, 50 to 70%, 75% of them are only going to deliver after 37 weeks of delivery of gestation. So we might say, well, we shouldn't worry about these patients because most of them would deliver late in pregnancy, but it's not the case for all of them. And we have to be mindful that if we delay the start of tocolysis at hospital admission, other of those measures that we can take for patients properly considered at high risk for preterm delivery, we might increase the risk of failure of these strategies. So it's really important to screen for spontaneous preterm birth in all pregnancies, looking for signs, clinical signs, risk factors, searching for infections, doing our antenatal care properly, and the tests that might be done. Some devices have been proposed to try to establish high risk, to differentiate low from high risk patients by measuring the cervix, but they are not that good for that purpose. So we must rely on ultrasound assessment. That it's really the best thing we can do for our patients, because we know that this cervical remodeling, this funneling, and this shortening, progressive shortening of the cervical length, it happens from the internal os and to the sternal os, like we see in this acronym here, trust your vaginal ultrasound. And ultrasound may be able to detect this shortening before our digital examination or before the use of other of those strategies that I cited before. And ISWOG has noted the importance of ultrasound, and we now have a guideline published since 2022 that I invited you to read. And some of the things that I'm going to explain from now on are recommendations from this guideline. So what we should look for in these patients with signs of uterine contractions, we should measure the cervical length, and we should measure it properly. So cervical length measurement should be the main aim for the prediction of the preterm birth for these patients, and using transvaginal ultrasound, as I mentioned before. We should do it properly. We should measure this cervical length at least 3 times and use the shortest technically correct measurement from those that we have obtained previously. And here is an example of a short cervix. Why should we do transvaginally and not transabdominally? As you can see here, when we obtain transabdominal images of the cervix, it's much more difficult to differentiate where is, or to identify where is the internal os, where is the external os. Sometimes the baby is here obstructing the view of the cervix. To better observe the cervix, we have to do it with a full bladder, and we have to compress transabdominally, what might artificially elongate the cervix. And this does not happen when we are doing it properly using transvaginal ultrasound. As we can see here, it's really easy to observe what we need to observe for these measurements. And this, as I said before, should be done in standardized ways. And we now have scientific bodies that certificate professionals how to do it properly, and also audit these providers to assess if they're doing reproductive measurements. So I recommend that you should, if you want to do these transvaginal assessments of cervical length, you should do one of these courses available for this purpose. I won't have time to explain to you the step-by-step on how should we measure these cervical lengths, but here is an example of how should we do it. We can do it in our consultation room, taking our mobile ultrasound, portable ultrasound. And what we should do is to put the transvaginal probe in contact with the anterior labia of the cervix, to do a little bit of compression to better identify the cervical canal. Where is the internal os? Where is the sternal os? Here we can see really clearly what from where should we measure to where should we put the caliper. There must be a magnification of 50 to 75% of the screen. We should not see a full bladder, and we should do proper measurement of the cervix. Not only the point of care ultrasound can be used for this, prediction of those patients that are going to deliver in the next days, but also point of care biochemical markers. And we have at least 3 of them, although fetal fibronectin is a little bit hard to find these days. But we have the placental alpha microglobulin 1 and the phosphorylated insulin growth factor binding protein 1. The main characteristic of these tests is that they have really good negative values. So if the test is negative, we have reassurance that the risk for delivery in the next days is low. But especially for patients at low risk of having delivery in the next days, the positive predictive value is too low. So we should use these tests only when for those patients that have high risk, that have symptoms of preterm delivery for the next days. There are apps that we can use and put clinical information, results from the cervical length measured by ultrasound or fetal fibronectin, and what we receive from these apps is a risk for delivery in some established weeks or in the next weeks, but we still need more studies to validate these in different populations and to know what would be appropriate cutoff for risk for delivery in the next days. These are the recommendations we have from ISWA guideline with regards to the management of these patients with threatened preterm birth. I will not read them, but I would like to pinpoint that the grades of recommendations are still low. We need more studies, so grade C or good practice points. But what we recommend is this: if a patient has symptoms of threatened preterm labor, and what we usually do is to do a transvaginal digital examination, and if the dilation is more than 3 centimeters, what we usually do is active management, hospitalization, tocilizis, corticosteroids, depending on gestational age. But we have more doubt for patients with dilation less than 3 centimeters. And what we usually do in these cases is to overtreat these patients. A lot of just-in-case hospital admissions. And what can we do better for these patients? To establish a protocol to use point-of-care ultrasound and point-of-care biochemical markers. So nothing changes if the patient has 3 or more centimeters of dilation. Active management will be the case. But for those patients with dilation of less than 3 centimeters, we should do the transvaginal assessment of the cervical length. And if the measurement of the cervix is less than 15 to 20 millimeters, and here there's no consensus. Americans usually use 20 and Europeans usually use 15 millimeters as this low cutoff. We should go for active management. The risk for delivery in the next days is higher. On the other hand, if the cervical length is 3 or more centimeters, 30 millimeters or more, we should go for conservative management if the patient, and consider discharge with precautions if nothing changes after some hours of reassessment. But we have doubts about what to do if we have this gray zone between 15, 20 millimeters and 29 millimeters. For those patients, point of care biomarkers might be useful. We should, if we have this in our arsenal, we should collect the swab before using lubricants or doing the transvaginal digital examination to have better results. And if the test is positive, we should act more actively and more conservatively if the test is negative. So this is our recommendation. But it's a recommendation for singleton pregnancies because unfortunately we don't have sufficient evidence for the use of transvaginal cervical length assessment or biochemical markers in twin pregnancies as we have in singleton pregnancies. So as my take-home messages, if we are going to see a patient with symptoms of threatened preterm labor, we should open our toolbox, not only to do the transvaginal digital examination, but we should consider using ultrasound and biochemical point-of-care tests, because they should help us to distinguish if the patient is a low-risk patient, long cervix, negative biochemical tests, and these patients should be followed more conservatively, should go home and come back if they have worsening symptoms. On the other hand, if these patients had low services or positive biochemical markers, these patients should be admitted and for more active management. So thank you very much.